I'll just comment on it now. That I'm going to show a study. It's a retrospective study that we started back when we first got the option filter. It was July of 2009. They had the first pre-market release. And I started collecting. He said, okay, I'm going to look at, at some point I said, I'm going to look at every patient that got an option filter up until a particular time. Basically, it was the time I could get it ready for the SIR meeting for an interim, some interim numbers. And I'll show you the results to that, and we're going to continue doing this to have a total of 1,000 patients. But I'm going to show you almost 400 here. Here are my disclosures, and so this is our initial results with the option, and we're going to continue to review and put about another 600, 650. I don't know the exact numbers yet because we have to pull them out of our database, but it's going to be a little bit over 1,000 filters and 300 retrievals, and that will be a mix of the option and OptionELITE. This current data is only for the option. Between July 2009 and September 2011, we looked at 371 consecutive patients that had the option vena cava filter, and we retrospectively reviewed this under an IRB protocol. All the placements were using the standard techniques that came with the filter, the standard sheaths. The filter retrievals were initially tried all with the standard retrieval techniques, but there were some additional retrieval techniques which I'll mention as we go on that we needed to use to get some of these devices out. 371 patients, 200 males, 170 females, averaged around 66 years old. You'll see there was a broad range. There was actually a 12-year-old in there, and you'd say, why does a 12-year-old need a filter? Well, this kid with a brain tumor and DVT and PE actually did need a filter. These were the indications. And as you can see, we do place quite a few for prophylactic reasons, but we have a pretty good distribution. A lot of them were DVT or PE with contraindication to anticoagulation. So we had 375 filters in 371 patients. Now, how does that work out? How do you have more of that? Well, 2 patients had a duplicated inferior vena cava, so they each received 2 filters. Well, one filter didn't open due to, and this is a weird one, it says a fibrin band, and actually one of my partners did this case, and there was looked like a wedding band, rubber band on the bottom of this filter, which we did take out because it didn't open, and it went to pathology, and they just said it was acute fibrin. I don't know much about it, never seen it before, never seen it since, but we replaced that filter, and of course, we had, somewhere that cartridge, you got to make sure you use the femoral and jugular correctly because we had one that was placed inverted. All those filters were immediately removed and replaced with a new device, and I don't count that as a retrieval in our longer-term retrieval data. We also had one that was deployed into thrombus that was repositioned. So we didn't count any of those. So a total of 373 cavas were enrolled. So those double filters counted as 2 cavas. Here was our median and mean cava size, right around 20 millimeters, with a plus or standard deviation of about 4 millimeters. The filter tilt on placement, it was pretty straight on most of these. And negative is to the right, plus is to the left. They all tilted a little bit to the right, but not very far on average. But there were a couple, a broad range, up to 20 millimeters, 20 degrees on a couple of them. But overall, they were pretty straight. We are also a jugular placement house. You can see 358 were placed via the jugular vein, either the right or the left. Very few femorals. So, and I also agree with Matt. The curved pusher doesn't do a lot for me, but we're going to hear more later about how to keep these nice and straight when you're placing them from the groin. Our retrieval population happened to be completely by accident, exactly 100 patients, pretty evenly distributed male, female, again, right around 60 years, 64 years, and a range of 12 to 86. And here's the indications for the people that had retrievals. And thankfully, most of the retrievals were in that prophylactic category. So of the 100 retrievals, we had one patient that presented on initial vena cavagram, had thrombus in the cone, and the decision with the clinician was that will remain a permanent filter, so that sort of fell out of our retrieval data. 99 patients we had retrievals attempted. Of that, we got 97 out. And you'll see an asterisk there. And the reason there's an asterisk there is one of those patients was a very straight filter, very easy to grab, very easy to oversheath, but it was very early in the experience, especially of one of my partners who said, I'm not going to pull quite that hard. I can guarantee today that filter would have come right out. But it didn't come out, so I have to count it as a retrieval failure. So here is our implant time. Median is 74 days, mean was 96 days, and the longest we had between 7. The longest retrieval we had was 474 days, and that actually turned out to be one of the easiest ones. Most of them were taken out using the standard snare and sheath technique, 88 of the 97, and we used what I call a tip deflecting wire technique. For those of you that were at Dr. Rayu's talks, it's basically a technique to try to break these tissue bands that hold the tip of the filter against the wall, and if we have time, I'll show you what that means. Looping a wire under the filter, sort of the standard techniques that Wilco or loop snare, to try to get them down and oversheath a tip that is embedded in the wall. These are the failed retrieval attempts. Patient 1, this is the one that was a real retrieval attempt. This filter is tilted. You can see 21 degrees. Penetrated. It's penetrated 7 millimeters. It's by far the longest penetration we had. And it was tried 3 times, once by one of my partners and twice by me. And ultimately, after in this 74-year-old who was completely asymptomatic, who actually had many other comorbidities, we just said, we're leaving this. I'm not going to go crazy. I don't have to get it out. The second patient, that's the one that I'm sure would have come out today. It was a very short procedure. It was not tilted, and I'm sure that we just did not pull hard enough. Migration in basically I looked only on our retrieval patients because a lot of our other follow-up patients didn't really have good imaging to try to figure this, but we had cavograms that I could truly match from the placement to the retrieval, and we had no migrations, with the definition of migration being anything greater than 2 centimeters. We didn't have anything that was greater than 9 millimeters, so that was great. No fractures, and I know I haven't seen as I said, I haven't done our follow-up on our 1,000 patients. I know that we have not seen a single fracture in an option filter and probably 300 retrievals. So caval penetration. Now this is an interesting category to look at because it starts with what's the definition of caval penetration. It dates back to a paper by Ernie Ferris from Little Rock, Arkansas back in the dark ages. I think it was around 1993. And it came out, the definition was 3 millimeters outside of the flow column of the cava. I don't know where that number came from. Maybe you do, but I've never figured out exactly where it came from before that. By strict criteria, I looked at this and said from the caval wall to the tip of the longest hook on the option filter, in 11 of those patients, it was outside the 3 millimeter range. In 6 of those patients, it was outside the 4 millimeter range. And every patient was asymptomatic, and frankly, I don't think this means much. I mean, true penetration may mean something, but these 3 millimeters, for any of these filters, I don't really think means much. Fluoroscopy time, well, average retrieval time was pretty short. The total time of 9 minutes was, mean and median were 5 and 9 minutes. Our shortest retrieval was 1.2 minutes of total fluoro time, so very, very short. And you can see of the patients that we did not retrieve, those were the fluoro times of the patient 1 that had the tilted filter we tried 3 times, and the patient 2 that we should have pulled harder. So whether our follow-up of our non-retrieved patients, median was 40 days, mean was 150 days, and the only thing we saw in our long data was 1 recurrent PE, and that was out of 274 filters. Admittedly, it's a retrospective study. The follow-up is not as stringent as you'd like to see. So follow-up of the retrieval patients, on average, we usually show those patients, looked at those patients 1 day later, and we don't have a lot of follow-up after the retrieval. But during their implantation time, we did have 1 iliocaval thrombosis, which was lysed, and the filter was removed. That's one of our successful retrievals. And I put down the penetrations were 11%, everyone asymptomatic. So what are our study limitations? It's the usual retrospective problems. It's a retrospective study, single center, very limited follow-up with clinical and imaging. But I hope when we expand this to another 600 patients, we will get some longer follow-up. We'll see some more imaging that's sort of accidental, but we'll have it. And I'm interested to see if there's any true differences that we can detect between the option and the OptionELITE. Matt talked about that there was a pre-market evaluation where a bunch of us got to place some of the OptionELITEs before it went out to general release, and I actually did place quite a few of them, and I had, I think, the most retrievals in the group, and I can say, anecdotally, I didn't have a strain gauge on it. They're certainly easier to pull. And again, I said, I don't have the exact data yet, but I have not seen any migrations. So, conclusions that I had: the option filter can be safely placed and retrieved. In our experience, it's demonstrated excellent clinical performance, minimal complications, and a high rate of retrieval success. This is one of the things that I just want to touch on. that one of the things I think is very important is if you want successful retrieval, you should think about it when you're placing the device. There are things you can do to try to make sure that your retrieval is going to be a success. One of them, this seems dumb, but make sure the access needed for the retrieval exists. If you're people that put them in, if you always put them in by the femoral approach, once in a blue moon, these patients may not have upper jugular or upper extremity access to get these things out. I've had that happen. I also had a patient that had a left-sided superior vena cava. Do I really want to do my retrieval through the coronary sinus? Didn't necessarily want to do that, so I put an Optese in that patient. That's the only Optese I've ever placed. Orient the hook so it's easier to see in the AP view. You can see it through the sheath, and sometimes you can twist the sheath and get it so that it's going to be very easy to see when you go to take this thing out. And I try not to place the hook of the filter exactly at the renal vein, so if the filter tilts, now the hook's way out into a renal vein. I'd rather have it above the vein. I'd rather have it below the vein. I just think it makes it easier to get out if it has tilted. And try to keep it centered in the cava if possible. And that's sort of going to lead us nicely into the next talk here, talking about over-the-wire placements and what techniques we can use to try to keep these things better centered. So thank you for your attention. The next speaker is going to be is Dr. Nizal. He's a vascular surgeon from University of Toledo, and he's going to talk to us about over-the-wire placement, which is something that has been recently approved by the FDA.